In recent years, some medical trainees and other physicians in the United States and elsewhere have gone on strike. With growing interest in unionization among U.S. physicians, the potential for such industrial action in healthcare will increase. I'm Stephen Morrissey, managing editor of the New England Journal of Medicine, and I'm talking with Carmel Shachar, an assistant clinical professor of law and faculty director of the Health Law and Policy Clinic at Harvard Law School. Professor Shahar has co-authored a perspective article about advancing physicians' collective bargaining rights and patient protections, in part by learning from other countries. Professor Shahar, what types of union-related activities have physicians in the United States engaged in recent years?
Traditionally, physicians have not been a profession that has been heavily unionized, but we're seeing that increasingly changing. And so we're talking at the beginning of January. Right now, for example, New York City is staring down a potential strike in four of the city-run hospitals. We've seen strikes happen really across the country, often involving medical residents. And I think this is something that we will come to see more and more of as the profession continues to unionize.
And then what about internationally? Where have physicians formed unions or initiated strikes around the world?
I think Americans might be surprised to find out, but physicians across the world have definitely engaged in significant unionization activities. A really notable one from 2024 was a strike of more than 12,000 South Korean medical residents, about 80% of residents in that country. But this is not just limited to South Korea. In 2024, medical residents in the United Kingdom went on strike. We've seen strikes happen among primary care physicians in France as well. So this is increasingly happening across the globe.
You say in your perspective article that the treatment of hospital employees under U.S. labor law has been complex and inconsistent. Could you describe how that treatment has changed over time and what does it look like today?
I think there have been some interesting trends, both on the law side and then how physicians are employed that interact with labor law. So the first thing for people to understand is that I think labor law initially kind of struggled to figure out what it wanted to do with physicians. When the National Labor Relations Act was passed in 1935, it originally covered employees of all non-government hospitals. Then in 1947, there was an amendment in the Taft-Hartley Act saying, no, we think that we should exclude employees of nonprofit hospitals from labor organizing. And that was the case for several decades until in 1974, we had the healthcare amendments, which restored labor law coverage to employees of nonprofit hospitals and also enshrined a right to strike for some, but not all, healthcare workers. And so what we've seen is the National Labor Relations Board try to figure out, okay, which physicians can organize. And a lot of that depends on whether physicians behave as supervisors. So there was a case that said, okay, if you are a tenured faculty member, you have some sort of supervisory managerial role, so you can't join a union, you can't organize, you can't strike. We've seen the National Labor Relations Act kind of try to determine, okay, when does a physician look like they're supervising? And there's case law suggesting, okay, we're not just talking about supervising nurses and trying to figure out where do we draw the line. Obviously, a medical director supervises a whole bunch of people. They probably shouldn't be in unions. But what about a physician who is leading a team of specialists, for example?
So, what types of protections do current U.S. laws and regulations provide for physicians who are attempting to engage in union-related activities? What's the landscape look like today?
Assuming that you are not a supervisor and you are not an independent contractor, so you are an employee of maybe a hospital or physician group, which I think increasingly covers more and more practicing physicians in the United States today, or you're a medical resident, you have labor organizing protections that are available. So you are allowed to join a union. You are allowed to have that union recognized as the entity that should bargain with your employer. And importantly, you are allowed to strike. Now, for strikes at healthcare institutions, the unions do need to give 10 days notice before a strike because, and I think that this makes sense, there is a certain tension or discomfort with strikes happening at hospitals. If a strike happens at a car factory, we have some fewer cars out on the road, which, depending on your feeling on cars, you might say is a good thing or a bad thing. But I think most people can say, okay, when hospitals' capacity is diminished, that's a concerning thing. That should only happen when there are a lot of guardrails and when it is really worth it.
In fact, what is known about how strikes in healthcare affect patients?
There are observational studies looking at this, and a lot of it I think might be surprising that there doesn't seem to be the impact on patient safety and outcome that one would initially expect. Now, some of that might be because there are a lot of procedures that are getting canceled because of the strike. And so you're not seeing that in the immediate impact, but you might be seeing that a little while down the road. But what it suggests is that if a strike is done thoughtfully to preserve emergency capacity, to say, okay, we will allow for a certain amount of capacity to deal with patient need that can't be postponed or rescheduled, especially in areas where there are alternative hospitals and alternative healthcare organizations that can take some of that capacity, strikes can be done in a way that is still respectful of patient needs.
You say in your article that U.S. laws and regulations could be updated to better reflect the realities of modern healthcare and could incorporate best practices from other countries. So, what lessons could be learned from the international experience?
One thing that is notable about the international experience is that there's a lot more work that has to be done to figure out, okay, how do you strike safely? And so in some countries, it's part of the collective bargaining agreements. Okay, when you strike, you're still going to give us a certain amount of physician capacity so that we can deal with healthcare needs. France, Italy, Ireland, Spain, I think all have minimum staffing requirements during healthcare strikes. And the United Kingdom has been considering a similar policy. Now, we have that 10-day notice, which is intended to give employers a chance to put together a plan for, okay, how are we going to keep the doors open, at least for emergency services? But I think it would be helpful to have, at least in the union contracts, a requirement that there be some sort of minimum capacity staffing requirements.
Finally, how do you expect the change in the federal administration to affect policies and activities relating to physician unionization? Do you think we're going to see more or less of it as a result of the change in the White House?
That is a great question. I think 2025 will be full of surprises for everybody in healthcare. The Biden administration has been very union friendly, we've seen, not specifically in the healthcare space, but more broadly in other strikes. And so I think it's fair to say that unions could rely on the White House to be very supportive during this administration. The Trump administration has not traditionally been as friendly to unions. So I think on that side, physicians who are striking shouldn't necessarily look for the White House to weigh in on their side. That being said, I really do think the cat is out of the bag. Earlier, I mentioned that more and more physicians aren't independent contractors. Their lives are that of employees. You get hired, you get told, okay, here are your hours, here are the policies. Sometimes leadership in a healthcare organization is really driven by administrators and not the physicians. And I think that, especially post-pandemic, we're seeing a lot of physicians start to articulate, okay, this cannot be the working conditions of my profession. And I think more and more physicians are turning to unions and labor organizations and even strikes as a way to push back on the trends that they see as taking control of the medical profession out of the hands of the everyday practicing physician and concentrating it elsewhere.
Thank you, Professor Shahar.